Afternoon. My name is Neve McGowan. I'm the Clinical Quality Improvement Specialist who tracks sepsis metrics for North Shore. September is Sepsis Awareness Month, and this presentation was put together to highlight how sepsis affects all areas of the hospital because it can arise from any infection. I will be your host for today's discussion on improving sepsis outcomes. We have an expert panel assembled today, which includes our lovely physician advisor, Michelle Loftus, the clinical impact team, pharmacy, and infection control. Without any further delay, I invite Dr. Loftus to start our presentation.
Great. Thank you so much for having me today. I appreciate any time I get to talk about sepsis. So get started. So the agenda today is that I'm going to start just by going over some of the metrics and some of the data we have. We have a little bit of new data with Vizient. And then we're going to go to our clinical impact team, who's having a really big impact in our hospital now, not only with rapid responses, but with the code sepsis that's been rolled out. And we're very grateful for their partnership. And then our pharmacy is going to speak and infection control as well. So the first thing I want to go out is kind of, why we care so much about sepsis is really mortality, patient safety and mortality. And here is some Vizient data, which is some new data that the hospital has really acquired to compare ourselves to other academic medical communities across the country. The top blue line is North Shore, that's our mortality rate. The dotted blue line is all of Northwell, and then the red area represents the worst 10th percentile. The green area is the best 10th percentile compared to all the other communities. So here we are. We've known for a while we have some opportunity with mortality and sepsis, specifically on the inpatient side, which is kind of why we're generating this whole code sepsis. The ED, the patients come in, they're septic right away. They stay in the ED for 6 hours. Everything's done very, quickly, expeditedly, and then they go to the floor. When a patient develops sepsis on the inpatient side, it takes a little bit longer to recognize. They have to wait for the vital signs, their Q8 vital signs, and then even then to escalate to a provider sometimes takes time. For the provider to assess them takes time. And so this has led to a mortality rate of around 40 to 50%. If a patient is diagnosed with sepsis in this hospital, the rate of mortality is 40 to 50%, which is too high. One of the things that prevents death is timely and effective care. One, which is how, surrogate is the bundle elements, the blood culture drawing, followed by antibiotics, followed by fluids if necessary, and then reassessment afterwards to see if they need a higher level of care or vasopressors. This is a metric that CMS, or the Center for Medicaid Medicare Services, really judges the hospital on. They review a select number of our charts every month, and they say, how many of your patients met all the criteria when they were diagnosed with sepsis. And you can see here, it's about 65% of the time we're doing everything that we're supposed to be doing for sepsis. And so this is, the real push with this is to recognize it quickly, escalate it quickly, and use the order set, which has all of the bundle elements in there, so that we get, credit for that, but also for the best outcome for the patient. So thanks mostly to your partnership in the inpatient side, we've started an inpatient screening process, which occurs once per shift. So every patient who has a MUSE of 4 or greater, which is a subset, kind of a higher risk population, they get a sepsis screen once per shift with the vital signs. And so on the, when you input your vital signs, there's a little radio button there that says, I screen for sepsis. Yes, that doesn't mean the patient has sepsis. It means that you did the screen. And here you can see the compliance with this screen has gotten astronomically better over the last 6 to 8 months. So I really thank you guys for that. And now we kind of have to take it to our side as providers to what we're doing with that information, since you guys are doing your part to screen the patients and escalate when it's appropriate. And without that, honestly, we wouldn't know where to start. So it's very important. We did review these cases. Of the ones that were screened, maybe half had the sepsis provider contact note, and of those, only half of the patients that were escalated had the full bundle compliance. So really this next step led to what is happening now with the code sepsis, where once a patient is identified with 2 abnormal SIRS, we really want to get it to, 1, to the primary team, but then 2, into a smaller quarterback, a specialized team to evaluate the patient and help make sure all of these elements are met in a timely fashion. And so this has led to the pilot that has started on 4 Monty, 3 Cohen with our clinical impact team. And I'm going to let them, come up, introduce themselves, and say everything that they're doing. I'm sure you're familiar with them. I had great experience working with them, and I'm very grateful for their partnership and hope that they're a support to all of us. And so I will bring the clinical impact team up for their part. And I'll stick around. Anybody can contact me anytime about any sepsis concerns.
Hi, everyone. I'm Ronnie. I'm one of the clinical impact nurses.
Garrett.
I'm sure you've seen some of us around the building. This is just a quick list of all of our team members. Our team is a mix of critical care nurses who have different backgrounds, who have started with this team over a year ago now. And one of the large initiatives that we are a part of, aside from responding to rapids and codes, is sepsis identification, sepsis education, and sepsis escalation.
Excuse me. So one of the big things, as Dr. Lockwood was saying, with sepsis, early detection and rapid treatment really improves the mortality rate. So we're helping support the staff by helping to identify patients high risk for sepsis, severe septic shock, educating on the importance of identifying the SEERS criteria and escalating appropriately to the providers. These are some of the tools that we've created just to help. One's just a list of the sepsis criteria. Think sepsis until proven otherwise, the big initiative that we had last September. And then badge buddies, which there are some in the back that we brought with us, just have the list of the SEERS criteria so it's easily available. And just a reminder, kind of the steps to take, which Bermuda is greater than 4.
So when we refer to SEERS criteria in the remainder of this talk, we're going to be talking about temperatures out of these ranges, heart rates in these ranges, and respiratory rate and white blood cell count or altered mental status. Common sources of infection for sepsis, 35% are lung etiology, 25% have a uroseptic picture, 11% are a skin infection, and another 11% have a GI or gut infection. So think about how many patients you have admitted that have some of these diagnoses. So any infection can cause sepsis, and it does not have to reach the bloodstream for it to be a sepsis diagnosis.
We were saying earlier, sepsis is a time-sensitive medical emergency. So it's a complex condition that occurs due to overwhelming systemic inflammatory response to any infection in the body. As Ronnie was just saying, infection does not need to reach the bloodstream for sepsis. The clinical signs of sepsis are the result of a chain of inflammatory and anti-inflammatory processes, humoral and cellular reactions, and circulatory abnormalities, including vasodilation, endothelial changes, and capillary leaks. The SEERS criteria is just one way to help identify it early.
So real quick, the sepsis cascade, back to a little patho. Your white blood cells meet bacteria. There's a cytokine release that recruits more of a white blood cell response. They actually release nitric oxide, causing blood vessel dilation. Platelets form little clots to try and plug up any of these leaky vessels. There's a tremendous fluid shift from intravascular to extravascular, which is one of the causes of hypovolemia. There's less perfusion and oxygen to the tissues. The red blood cells can't penetrate the cellular membranes. And as a result of all of this, we see an increase in lactate. We see tachycardia, tachypnea, leukocytosis, hypotension, abnormal PTTs, INRs, bilies, and thrombocytopenia.
Discussing earlier, the Muse just helps identify patients at risk for deterioration. Kind of catches subtle vital sign changes. Any patient with a Muse 4 or greater needs to be sepsis screened. And then from there, you're going to identify the SEERS criteria to see if it needs to be escalated to the providers.
So some people have had questions about how a Muse score is actually calculated. It is done through Sunrise, right? Basically, there's some clinical criteria, including systolic blood pressure, heart rate, respiratory rate, temperature, level of consciousness, body mass, and age. And usually this is comparing to like the last set of vital signs you're seeing also. So some of these things are objective things we can't change, right? Age, body mass, but so you might have a higher Muse than they might have, even if they're not showing other clinical criteria because of age or body mass. But this is sort of your modified early warning system scoring tool that's going to be assessing all your patients in the same way.
The Muse just identify, so as we saw, you can kind of calculate the Muse. From there, you're at the bottom of the vital signs screen, you're going to screen for sepsis. And there, that's when you're going to look at your serious criteria: heart rate greater than 90, respiratory rate greater than 20, either febrile or hypothermic, a white blood cell count greater than 12,000 or less than 4,000, and an altered mental status. If you have at least two of those, then it's when you're going to escalate to the provider, and you're going to use the provider contact note in Sunrise. And then they would use that's when we're trying to get the providers to use the order set to make sure to complete the bundle.
So just a quick review. Some of these words are sometimes used interchangeably, but there are distinct differences between them. So sepsis is your 2 Sears criteria, the clinical signs we've talked about, with a source of infection. Severe sepsis is your 2 Sears criteria, at least a source of infection and end organ dysfunction. This is when we might see things like bumps in your creatinine, changes in your LFTs, things like that. We have the 3 and 6 hour bundle that are on the screen, which although the providers are the one putting these orders in, it's our responsibility to make sure that these are being completed and reassessed in a timely manner. And then septic shock is when you have 2 Sears criteria, a source of infection, evidence of end organ dysfunction, and you have a persistent lactate or hypotension despite being fluid resuscitated already. At this point, the patient generally is becoming a little more unstable, and if their hypotension persists, they generally need vasopressors or things like that, which would bring them to a level of care in the ICU. This is just a visual of the same thing we talked about. We can give this to people if they want this content.
This is our new pilot program that we're working with 3 Cohen and 4 Monty to begin with. It's going to be the code sepsis. Basically, if you have 2 positive serious criteria and new or worsening sepsis, they're going to call the operator, same process as calling like an RRT or a code blue, to which point we'll get a page. Within 30 minutes, we have to respond. We're going to come to the bedside, the CIN team, the primary nurse, and the primary team caring for the patient to have a huddle to discuss the serious criteria and if we feel this is new or worsening sepsis. If there is, the hospital is busy, if something comes up where the primary team's unavailable due to another emergency, we are going to be utilizing our telehealth EICU doctors as well to help with ordering the bundle in a timely fashion. And then assuming we agree that everyone agrees it is a code sepsis, the provider will open the bundle and we'll just be following up to make sure the 4 and 6 hour, the 6 hour bundle is completed. We're aiming for 4 hours just to give ourselves a little bit of leeway in case there's some other emergency that kind of delays things.
We just wanted to wrap this up with a case study. This is a patient that was actually here. Basically, we had a 72-year-old male. He was admitted to a medicine floor directly from his primary care physician's office for some hypertensive urgency. They wanted him checked out. They wanted some of his blood pressure medications adjusted. He had a history of hypertension, hyperlipidemia, a CVA with mild left-sided residual weakness, but he was still completely independent. His initial assessment, he was ANO3. Blood pressure was 160s over 100s. It's part of why he was here. Heart rate was 70s, normal sinus. Respiratory rate 16, satting 98% on room air, and he was afebrile. His initial lab work for the day was unremarkable. Everything within normal ranges.
You can see the patient starts to deteriorate. Patient still ANO times 3, blood pressure is beginning to drop a little bit, 150s over 90s. Heart rate's becoming a little tachycardic, low hundreds. Respiratory rate's now 22. Still satting well in room air, 96, but patient is also febrile to 102. So you'll see some of the bundle is completed. The primary team ordered blood cultures, they had a VBG with lactate. Patient got a gram of Tylenol. Lab results came back a little abnormal. Now we have a white blood cell count of 13,000. Patient did create a lactate 2.4. But you see the end organ perfusion markers are still stable. Creatinine and liver enzymes are still normal. So after the lab results came back, the primary team did order IV maintenance fluid. A straight cath was sent for a urine sample that came back, the UA came back positive for bacteria.
So these are all appropriate, but this is not completion of the bundle. Okay. So basically on the second day overnight, there was a big change in the patient's clinical status. They were ANO times 1 to 2, very lethargic. Blood pressure was down to 100s over 70s, sinus tach into the 120s, respiratory rate was in the mid 20s. They had to start some oxygen by nasal cannula to maintain a SAT above 90, and the patient had 104 fever and was rigorous. The nurse called a rapid response. The team responded. They put in 2 large bore IVs. The patient got a liter of LR fluid as a bolus. IV antibiotics were initiated and ID was consulted. They got another dose of IV Tylenol. Cooling measures were started, including a cooling blanket, and orders were placed for a repeat lactate in 4 hours. And the patient was transferred from medicine to telemetry for closer monitoring of the heart rate. The lab work during the rapid resulted with a white count of 16,000. Lactate was up to 9.4. And we now have signs of end organ hypoperfusion. Sorry.
As you see on the next day, now patient got the appropriate treatment. Patient mental status improved. They're back to their baseline of ANO times 3. Blood pressure is recovered closer to their baseline, 140s over 90s. Heart rate's lower, 96 normal sinus rhythm, satting 97% on room air. Still mildly febrile. The white blood cell count is coming down. The lactate had cleared with the treatments, and end organ perfusion was improving. So you see those labs begin to improve as well.
And this patient was discharged home and is okay. This was just a good example of while the patient didn't require critical care, they could have gotten worse. They could have definitely decompensated. And also the hope is that we can implement these full bundles and prevent the patient from even decompensating a little bit in the first place.
To avoid the rapid response that had happened overnight. If the whole bundle had been completed when sepsis was originally identified earlier in the day.
Got it? Any questions? Thank you. What was the question? I'm sorry. Muse doesn't populate for ICU.
No.
Right? Okay. Yeah, so in the critical care setting, there is not a Muse that is populated for the patients. It doesn't come up on the flow sheets. In critical care, the practice is to screen the patients based on this criteria, but you're not looking at an actual number. They are still screening the patients and communicating if the patient's coming outside of the ICU about which of this criteria they may or may not meet for the protocols. All right. Thank you.
Excellent. Thank you so much, Clinical Impact Team. So now I would like to invite Patricia Saunders-Ho from our pharmacy team to come in and do their presentation.
Afternoon, everyone. So my name is Sumit Jain. I'm one of the ID pharmacists here at North Shore. This is Patricia Saunders-Howe, our other ID pharmacists. So we're a team of 3 ID pharmacists, Sumit, myself, Patricia, and Kirby. And then we also have our ASP director and our ID physician, Dr. Pranisha Gautam Goyal. And so today we'll just be talking about optimizing antimicrobial therapy and sepsis. So we'll be discussing key factors in determining appropriate therapy, antimicrobial therapy for patients presenting with sepsis, review the antimicrobial recommendations for common ID conditions, and then highlight some of the available resources that we have to guide antimicrobial therapy. So in general, we know that antimicrobials are prescribed quite widely at most hospitals, and our hospital is not excluded from that. But when we're thinking about antimicrobials are being prescribed, there's always a key moment in each sort of the phases of antimicrobial prescribing where we can improve overall prescribing of antibiotics to make sure that everything is appropriate. So this is just a figure from the CDC showing how in each step of his patient's sort of a hospitalization, how things could have been improved, all the way from initial diagnosis up until when the patient was discharged for appropriate antibiotics to go home. And so when we're thinking about antibiotics, we're always trying to think about four of these sort of really key factors, which is the right drug. We obviously want the right antibiotic for the right bug that we're trying to treat, the right dose and the frequency, and the right overall duration, because all of these things will impact our patient's care and other collateral damage that could happen if appropriate antimicrobial therapy isn't given. So when we're talking about sepsis and antimicrobial stewardship, it's a bit of a balancing act because with sepsis, some of our fears include undertreatment, right? We talked about, and delays of antibiotics, which can all lead to increased mortality in our patients who come in with sepsis. And on the other hand, we have antimicrobial stewardship principles because we know that overdiagnosis can also lead to overtreatment of patients, and overtreatment of patients giving antibiotics when it's not appropriate can also lead to increased collateral damage. So I just wanted to talk about a couple of studies that talked about, what is the sort of balance between sepsis and overall antimicrobial prescribing. So we had the study that came out a couple of years ago looking at empiric antibiotic therapy, meaning patients, who were just giving for empiric therapy for sepsis when they presented and what the consequences are of inappropriate coverage. So this is a study that looked at over 17,000 adult patients in over 100 hospitals in the US. And they were looking at patients who had a diagnosis of sepsis and they had some kind of a culture that was positive. And their objective was to look at outcomes associated with either undertreatment and overtreatment with culture positive sepsis. And so what do they find? So obviously, I think, which we probably would expect, if patients were undertreated, meaning that their empiric therapy was inadequate, there was higher mortality, which I think we all sort of know. But they also found that patients who were giving too broad of therapy, meaning they were overtreated, also had higher mortality. And so the takeaway here was that both options really were bad for our patients. Whether you're giving patients less treatment or more treatment, it could actually lead to a negative outcome. So we're always trying to sort of find this right balance between sepsis and appropriate antimicrobial prescribing overall. And then one other thing I want to mention was because this has come up sort of before, with sepsis in general, we know, we just heard about the bundle and how we want to give all these things in a timely manner. And antibiotics are obviously included in that to make sure we're giving antibiotics, as soon as possible when sepsis is identified. So we're always really, keyed in on that first dose of antibiotics, but sometimes we also forget that second dose of antibiotics is just as important. When we have a patient coming in through the ED, that first dose is stat. Sometimes that second dose can be forgotten, and we've noticed that sometimes these issues have come up. Patients are being between units in the ED and outside the ED, going up to the unit, and that second dose may be delayed. And so I wanted to just talk about a couple of studies that showed what the effect is of that second dose delay. This first study at the top showed that delaying the second dose of antibiotics can increase mortality. But then we also have, on the flip side, the second study at the bottom that showed that maybe it didn't have that change in mortality. But I think the message we want to send is that as important as that first dose is for sepsis, that second dose is just as important. The first 48 hours of when patients are presenting with sepsis and they have a true infection are the most important for making sure that they were giving the appropriate antimicrobial therapy. So just to highlight, the first dose is important, but that first 48 hours is very critical to making sure that our patients will have appropriate outcomes. And so with that, I'll pass it on to Patricia.
Thanks, Sumit. So in terms of choosing an antibiotic, there's different factors that we consider, including allergies of patients, the site of infection, and possible pathogens, as was sort of alluded to earlier. It also depends on, healthcare associated pathogens, renal insufficiency and body habitus, depends on prior cultures, if they've had more resistant organisms in the past, as well as drug-drug interactions. And so this was alluded to before in terms of thinking about the source of infection or the potential source of infection and sort of trying to target the antibiotics according to the source of infection. And so these are some common sources. including empiric, where you don't know what the source is, pulmonary, whether it be community-acquired pneumonia or hospital-acquired pneumonia, skin and soft tissue infections, intra-abdominal infections, urinary tract infections, line infections, or neutropenic fever scenarios. So the Sunrise order set for sepsis actually bundles everything all together. So it doesn't give much guidance, unfortunately, to choosing the right antibiotic based on what you're suspecting. It just lists basically in alphabetical order all the antibiotics that you could potentially give. And this is, so that was the ED order set. And then the inpatient one is a little bit smaller list, but still doesn't provide any guidance. So the good thing is that come Epic, we will have more guidance available, and just wanted to share this with you all. So when in Epic, when a provider goes to order antibiotics for sepsis, they will be given this menu of options. And then this menu will basically prompt them to choose different antibiotics, which again is what we would ideally want to do. And within each of these, there provides some guidance, even in terms of duration of therapy, what combinations you would use, even guidance in terms of allergy assessment and when you would give which beta lactams in the case of a beta lactam allergy. Similarly for, that was unknown source. For pulmonary source, it basically goes through the whole algorithm of choose, what they're at risk for, and then prompting the provider to pick different antibiotics based on their responses. So this is the community acquired pneumonia one, where it prompts them even for appropriate culturing, just so that you're aware of what's coming. And then similarly with a urinary source, it goes through and provides guidance when you might want to select different antibiotics. And in choosing antibiotics, how would you do this? So one of the main things that we remind providers to do is look at the antibiogram, and in determining which antibiotics you might want to choose initially. So this is an example of the ED antibiogram. The E. coli is highlighted here just to illustrate that, based on the antibiotic, that they have varying susceptibilities, and even our ESBL rate, for example, is listed. So if you have a high risk patient, that might be something that you might need to keep in mind. Certainly prior cultures also are extremely important. And then similarly, this is the gram-positive antibiogram, and what's highlighted is clindamycin. So we do see a lot of clindamycin being used in the ED for skin and soft tissue infections. And this is just to highlight that with the 70s susceptibility for MRSA, that's probably not the best drug to use empirically. So again, all our tools in trying to determine what might be the best antibiotic therapy to give your patient. This is the inpatient antibiogram, and for this one, highlighted the resistance rates for the carbapenem-resistant organisms, as well as the ESBL rates, when you might think about using other antibiotics that are not typically the first line. And then if any of you are not aware of our First Line app, it is a free app that you can download and have on your phone. And it basically provides a lot of guidance in terms of dosing of antibiotics. We put a lot of our ID guidelines on there. So please download it, use it. If you have any suggestions, please let us know. But that is available free to everyone. And this is kind of what it looks like. There's several guidelines, and we're continuing to update it with more information. And then just lastly, I wanted to make a plug for influenza vaccination. So we're coming up on flu season. So just as a reminder, please try to get your flu vaccine. Now it seems to be tied to CMS reimbursement. So please, remind your colleagues, let's all try to get our flu vaccination so that we can keep our patients healthy. That's all I have. Thank you.
Thank you again, pharmacy. So next up, I'm going to invite Aradna to speak on behalf for infection control.
Alrighty, good afternoon, everyone. My name is Aradna. Let's see my slide. All right, so I'm sure you pretty much heard a lot about sepsis today in the last 45 minutes. So I'm going to go through our slide from infection prevention. Sepsis, we call it the equal opportunity killer in the infection prevention department. As you can see, this is the statistics really out there. It's like 5+ million worldwide, including children too. And this is how much Americans die from sepsis each year. It is one of the third leading cause of death. I think it bumped up COVID. And also 55% of Americans have ever heard of the word sepsis. So put it out there. So this is our sepsis statistic. So it really is the body overwhelming and life-threatening response to infection, which could lead to, of course, you guys know this really well, organ damage and death. And it is a really, truly medical emergency, and you guys deal with it almost every day. It's approximately 6% of all hospitalization are due to sepsis. And about 35% of death in hospitals are due to sepsis too. And of course, that's the statistics. Depending on which website you look, they give a bunch of different statistics, but it is over 200,000 cases. It leads to readmission to the hospital with as many as 1.9% of people originally hospitalized for sepsis are re-hospitalized, believe it or not, within their 30 days. And about 40% are re-hospitalized within 90 days. So they do come back to the hospital. So as many as 85% of sepsis cases originated in the community and not in the hospital. So good thing. What is the mechanism? So what did I say about it's a good thing? In terms of capturing as a hospital-acquired infection, because we do have so many matrix in infection control like CAUTIs, um, MRSA bacteremia, CLABSIs. So if all of this is captured when the patient's coming into the hospital, it's a great thing the first 2 to 3 days. So it's all get tagged back to the community and not necessarily a hospital onset, and that we gave it to that patient. So what is the mechanism leading to sepsis really? The endothelium is a fundamental function unit in the pathophysiology of sepsis, and it really plays a great role in the regulation, of the body and the inflammatory and the anti-inflammatory process. I'm pretty much not going to go through the whole slide, but it does cause so much damage to the lining, and it just raises the interstitial pressure and worsening. Most important, it just worsens the tissue perfusion of the patient. So, what factors have led to an increase of sepsis? The incidence in sepsis and septic shock has continually increased since the first definition in 1991. And this was interesting when I looked it up. So it was first defined in 1991. So the alarming increase in incident can be attributed to, again, a lot of different factors, and our colleagues did say it. Of course, age, the advanced age of our patient, the increased number of invasive procedures that are done, the wide use of immune suppressive drugs, and like your TNF factors and chemotherapy, etc. And of course, a rising antibiotic resistance. So causes of sepsis, so the frequency identified, the microorganism in septic and septic shock, it has varied over time. So recently, when I looked all of this up, is all the gram-positive that is most frequently associated with sepsis. So that's your Staph aureus, your Streptococcus, and of course the Staph epi. The gram negative is usually associated with the E. coli, Klebsiella pseudomonas. A lot of it is found in the belly and the GU. And of course, up and coming is the fungal infection, most frequently associated with sepsis is the Candida. And you do see a lot of Candida species if you look up the culture results of your patient. And the Candida is really, most of the time, we see it in the immune compromised patient or the patient who's undergoing long-term chemotherapy. They're the ones who are very, very prone to getting the fungal ones. So this is, and our colleagues went over this already. So what is sepsis? And I'm sure you guys are well aware of this. The SIR, the severe sepsis definition, which is the organ dysfunction, and then really septic shock, which is a lot of hypotension and needing a lot of fluid resuscitation. So the signs and symptoms of sepsis, I'm not going to go through it, but you guys are very familiar with it. Shortness of breath, fever, lots of fever, and heart rate issues. So signs of organ dysfunction. This is the numbers I got for the hypertension, lots of kidney issues with the elevated creatinine, decreased urine output, elevated bilirubin, decreased platelet, INR, and elevated lactate. So who's at risk for sepsis? So the group that most likely falls on in this category are the 65 and older, which is a lot of our patient population, patient with a lot of chronic conditions, your diabetes, your cancer patients, kidney disease, transplant patients too. Please remember we do take care of a lot of transplant patients, so they do fall into this category. It could be of any age too. People who have survived sepsis, people who have really weakened immune system and severe illness or hospitalization, and of course, young children. So I know my colleagues also speak about this, but the common sources, of course, the number one is respiratory with the pneumonia, and flu season is coming up, so please take your flu vaccine. So pneumonia, the genitourinary UTI, believe it or not, is the second most common cause of infection. Then you have your GI, with its peritonitis, appendicitis, diverticulitis, then the bloodstream infections. And this can happen because we do have patients who have central lines, midlines, PICC lines, and tunnel catheters, and of course IV. IV associated with a phlebitis can also cause a sepsis, and skin wounds and meningitis and encephalitis too. So some of the primary pathogens that are easy to miss with the sources, of course, is I did talk about this with your staph, your pneumonia, the meningococcus, the influenza, which the season is coming up, and then listeria, listeria is like more of a foodborne, but listeria. You do see sometimes a lot of listeria with the nursing home patients, and that's a reportable condition. So other aspects of sepsis identification, of course, source control, whether it's the bladder, the blood. We do use a lot of our lab uses a lot of technology to get the results faster to the provider. So it could be like a faster treatment and the appropriate treatment with the antibiotic. But they do have something in the lab called BCID, which is it just identified the organism that's causing the infection earlier, which is great. And we have a lot of genetic markers of resistance, so you'll see it. We call it the CARBA5 panel, but you'll see when you look at the results of the patient. Is it like a KPC? Is it an NDM? Is it a VIM? OXA48 and IMP? So this is all resistant organism, and that's when our antimicrobial stewardship comes in with the physician and make sure the treatment is appropriate. And again, all of this carbapanel 5, it also has to get reported to the State Department of Health because it's so resistant. And they do want to keep track of it. And also, it's not just the patients that we have to report, all of their roommates. Like subsequently, if they develop, so there's going to be like a match. So, and I'm going back on this, is when the CDC set new standards for hospitals to combat sepsis. I'm sure you guys know this story. How many of you guys know this story about Rory? Yeah, right. So this was in 2012. It was like a Wednesday afternoon, and it was a 12-year-old boy named Rory who got a scrape during a middle school basketball game, and his gym teacher just put bandages on his arm, which is normal. We all would do that. By Thursday, he had a fever, vomiting, leg pain. And then he went to the hospital. They attributed his symptoms to dehydration and have him go through fluids and anti-nausea medicine. And then by Friday, he was really critically ill, and by Sunday, he passed on. So this was a story. It was really on the news in 2012 and was just widespread, and it's really a sad story. But this is was how sepsis really got started. And a decade later, they release new guidelines for a hospital to detect sepsis early and treat it early. And I think that's why we have all the guidelines now. So despite the prevalence of sepsis, often hospitals often misdiagnose the illness because it's masked with other symptoms such as fever, shivering, clamminess, and shortness of breath. Sepsis detection and care requires a lot of coordination, as you guys can see from all of us. And a survey of over 5,000 hospitals found that about 73% of the hospitals has a sepsis team, which we do have a sepsis team, but only 55% had a leader with a time to allocate to manage and control the program. So that's what everyone is advocating for, is to have a great sepsis program so we can prevent the next person from dying, basically. And I think that's the last of my slides. Do you guys have any questions?